Dear friends, I am going to now present an algorithmic approach for a case of hypercalcemia. Do you suspect hypercalcemia in a given patient by his presentation? Like your stones, bones, groans and moans? Or do you think there is a hidden hypercalcemia as the reason? Or you routinely screen for hypercalcemia? The test that you order is serum calcium. Once you get the total serum calcium, we use the correction factor for obtaining the corrected serum calcium depending upon the albumin value, which we have already explained. So, if the serum calcium is between 8.5 to 10.3 and that is normal value, we call it as normocalcemia and no more investigations are needed. If the serum calcium is below 8 milligrams percent, then it is a case of hypocalcemia. But in this lecture, we are not concentrating on hypocalcemia, but we are more interested in looking at hypercalcemia, that is serum calcium corrected to the level of albumin of the patient. If it is more than 10.3 milligrams percent, it is a case of hypercalcemia requiring investigation. Let us see the next slide of the algorithm. The next important step would be, if the serum calcium is more than 10.3 milligrams, is the patient taking any medications which could cause this hypercalcemia? Like, is he on chronic thiazide diuretic treatment? Is he taking vitamin D supplementation? Is he being injected vitamin D by the doctor, by his family physician, or is he himself taking vitamin D in any other form? Or milk alkali syndrome, excess of alkali consumption for peptic ulcer along with milk products, or is he on treatment for depression with lithium salts? This history has to be elicited, and if so, that medication has to be discontinued and hypercalcemia rechecked. But of course, if we do not have anything in the history suggestive of any medications causing hypercalcemia, then we have to order for the test called IPTH. It's also called intact PTH. The serum has to be examined. Take the patient's blood, separate the serum and put it in an ice box and send it for IPTH. If the IPTH or the intact PTH value is high or normal, then we are dealing with a case of primary hyperparathyroidism, which is one of the commonest causes. We have already seen primary hyperparathyroidism and malignancy are the two important causes of hyperparathyroidism. So, if the IPTH value is high or normal, we are probably dealing with primary hyperparathyroidism, and we need to do a nuclear scan of the parathyroid to confirm the diagnosis and plan the treatment. If the IPTH is suppressed, it means that the parathormone is suppressed due to excess calcium, and the excess calcium is coming from some other source, either due to vitamin D toxicity or due to milk alkali or due to any hidden malignancies and lymphomas. In such a case, we have to do a test what is called parathyroid hormone related peptide in order to confirm humoral nature of the malignancy causing hypercalcemia, humoral hypercalcemia of malignancy. So, if the patient's serum calcium is more than 10.3, we take a history related to the medications and then rule out those causes. Then we order for IPTH. IPTH is high or normal, we are dealing with primary hyperparathyroidism. Ask for a nuclear scan of the parathyroid. If the IPTH is suppressed, we are dealing probably with vitamin D toxicity, milk alkali syndrome, or some hidden malignancies or lymphoma, in which case we need to order for parathyroid hormone related peptide. Let us see the next slide in the algorithm. So, if the IPTH is suppressed, then we have ordered for PTHRP, PTHRP can be low or normal, which means some endocrine cause is the one which is causing hyperparathyroidism, like acromegaly, pheochromocytoma, adrenal insufficiency, more commonly hyperthyroidism itself. It could be low or normal. In such a case, if there are no endocrinopathies underlying, then we do 125 vitamin D levels. If the 125 vitamin D3 levels are low, then it is suggestive of cancer. If they are high, suggestive of lymphoma. On the other hand, if the PTHRP is very much elevated, it is a humoral hypercalcemia of malignancy, then we will do a 24-hour urine calcium. If the 24-hour urine calcium is low, then we are dealing with a case of familial hypocalciuric hypercalcemia. If the 24-hour urine calcium is normal or raised, we do a system AB scan to look at the parathyroids. So, this is the algorithmic approach of a case of hypercalcemia being investigated stepwise. This scattergram gives us the relationship of serum calcium and the intact parathyroid hormone. On the x-axis, we see the serum calcium levels in milligrams per deciliter, in within brackets millimoles per liter. We will look at milligrams per deciliter. 6 milligrams per deciliter to 16 milligrams per deciliter. We know the normal value is anywhere between 8.5 to 10.3, and this is the normal range. And in such cases, the parathormone levels, which are represented here on the y-axis, in 50 picograms per ml, 100 picograms, 150, like that, picograms per ml of intact parathormone, and the normal scatter will fall somewhere here. Serum calcium will be within this range of 8 to anywhere between 8.5 to 10.3, and the parathormone levels will be around 50 to 75 or something like that, picograms per ml. So, if it is a case of primary hyperparathyroidism, there will be excess of IPTH, and parathyroid hormone will be in the range of more than 100, 150, 200 picograms per ml, and the serum calcium will be anywhere between 11.5 to 15 or 16. So, this is the level of serum calcium, and this is the level of the parathyroid, and this is the scatter of primary hyperparathyroidism. On the other hand, hypercalcemia associated with malignancy, the parathormone is suppressed because of high levels of calcium. We see very high levels of calcium, hypercalcemia in the range of 11.5 to 15.5, but the parathormone is suppressed and it is less than 75 or 60, or in fact sometimes it may be even as low as 10 picograms or even lower than that. So, this scatter is the scatter of malignancy, and of course, we have got hypoparathyroidism. In hypoparathyroidism, we have very low levels of circulating IPTH and very low levels of calcium also. So, there are 4 scatters here. Looking at the scatter itself, we can say what case we are dealing with. This scatter is the normal calcium level and normal parathormone level. This is a case of hypercalcemia with hyperparathyroidemia, that is IPTH is elevated, and this case is a suppressed parathyroid with high calcium levels due to malignancy. These are cases of hypoparathyroidism where the calcium levels are low and also the parathyroid hormone levels are low. This is how we can relate serum calcium and IPTH in the scatter and arrive at a diagnosis. This, in addition to the algorithm which we have seen, can give us a definitive diagnosis of the cause of hypercalcemia.